So is my slide visible?
Yes, sir, perfect.
Okay. So today we're talking about primary adrenal insufficiency. Before I go on further to what is primary adrenal insufficiency, I'd like to tell the audience something about what are adrenal disorders as such. So they are these, they are small glands. These are situated just, they're triangular shape, which is located just above the kidney. They're sometimes called suprarenal glands by general public also. Their job, what is the job of these adrenal glands? They make hormones that keep your metabolism, your blood pressure, your immune system, and stress response in balance. So these, what are the hormones which are produced by the adrenals? These hormones mainly are the hydrocortisone, which is also called cortisol, adrenaline, and aldosterone. So there are different conditions related to adrenal gland. The commonest, which we'll talk more about today, is adrenal Addison disease, acute adrenal insufficiency, also called adrenal insufficiency. Here, what is happening? Your gland is not producing enough cortisol or aldosterone. Then the Cushing syndrome. In this disorder, your level of cortisol too high. The term can be applied when large doses of steroids are given to treat certain medical conditions. Okay, sometimes you give excess of cortisone to a patient, to a person, that may result in Cushing. Then we have a very common in which we see in newborns and some infants, maybe seen adults also, congenital hyperplasia, which not been picked up and picked up later on in life. So this is a genetic condition which when with the adrenal glands are not able to make cortisol very well. So as a result, ACTH from the pituitary is elevated. So depending on the defect of which level the level defect is, you may get male hormones may be made which one is higher than normal. So adrenal gland suppression, this is a type of adrenal suppression that is related to an outside source of cortisol or related such as prednisone is giving to it. So it suppresses the adrenal gland. Okay, that's another thing. Then you have hyperaldosterone, again related to the adrenal gland. Here it produces too much aldosterone, which can lead to blood pressure elevation and potassium loss. Virilization, when your body produces too much of male testosterone, is only apparent in female and boys before puberty. So there may be tumors of the adrenal gland, which may be benign tumors, or maybe adrenal carcinoma, or a pheochromocytoma, and pituitary tumors may cause some change in because of the ACDH abnormal growth of pituitary gland may cause disrupting the hormones from the adrenal gland. So ACDH producing tumors may cause Cushing disease, and some of the tumors pituitary may become large, and they may even press on the normal pituitary cells and cause deficiency of ACTH and secondary adrenal. So this is secondary adrenal. So there are two: primary adrenal insufficiency and secondary. So I generally give you an idea of what are the various adrenal disorders. Now coming on to the most our topic today is primary adrenal insufficiency. So in primary adrenal insufficiency, when do you suspect on a newborn and an infant? When a baby is having failure to thrive, and not mother and father coming to you, and the baby is not catching or not growing at all. Recurrent vomiting, think of one very important thing, maybe is acute adrenal insufficiency. Then hypoglycemia. Hypoglycemia is also there. And then, we all poor feeding. Baby is not feeding very well. This really is, most of the time the pediatrician or the neonatologist think that it is sepsis. So the cause of this is sepsis. Actually, this is a case of acute renal insufficiency. So just giving cortisol to the hydrocortisone of the child improves everything. So keep this in mind. Very, very important to be suspicious with such condition and with these type of symptoms are there. So the acute adrenal insufficiency in some cases may lead to adrenal crisis. The features are, dehydration, as you were talking in the beginning in the introduction, dehydration, hypertension, shock, which is out of proportion to the illness. So the child is not that ill, but the child is in shock. He doesn't have toxemia, he doesn't have any sick feeling, sick like. So there is them. And then, nausea and vomiting with history of weight loss and anorexia, loss this thing. Abdominal pain, very, very common, acute abdominal pain, adrenal crisis, unexplained hypoglycemia. Why the patient is having low sugar? Why does patient have unexplained fever? Think of adrenal crisis. Hyponatremia, hyperkalemia, azotemia, hypercalcemia, eosinophilia. All this presentation can be there when patient having adrenal crisis. And pigmentation, very chronic adrenal insufficiency will lead to pigmentation, even sometimes it live. So then you must always try to feel that there may be some other autoimmune disease, there may be some hyperthyroidism, there may be gonadal failure, so there may be other endocrine deficiency may be there. So these features may be seen in this patient with adrenal leading to adrenal crisis. So what are the clinical features? Now, as I told you, there are three hormones mainly: aldosterone, then you have cortisol, then you have, the other one is also there. But We'll be talking mainly on the three hormones. We're not talking about adrenaline, the hormones, which is mineralocorticoid and glucocorticoid. So these two hormones, based on their deficiency, which is called, that's how you get a symptom and sign. So if the patient has got fatigue, lack of energy or stamina or reduced strength, most probably it is glucose deficiency, and that means it means some, along with that, he may be androgen deficiency. So these are something which you can find. And there, if the patient has anorexia, has weight loss, especially in children, failure to thrive, think of glucose deficiency. That means there is involvement of the glucose. If the patient has gastric pain, there is nausea, there is vomiting, which is very commonly seen in primary adrenal insufficiency, think of glucose deficiency, mineralocorticoid deficiency. Myalgia, joint pains, he comes with joint pain, myalgia is there, click a glucose deficiency. If there is dizziness, think of mineralocorticoid deficiency, glucose deficiency. Salt craving, very, very common. Want salt. It's a primary adrenal insufficiency. So main thing factor will be it's a mineralocorticoid deficiency. Very commonly seen in primary adrenal insufficiency. If there are dry itchy skin, can be seen in women, mainly adrenal and androgen deficiency. Loss of payment or libido, adrenal insufficiency. So you have, these things happening in the adrenal glands. So this you can see. Now, what are the signs? Skin hyperpigmentation. This very, very common. Mainly seen in primary adrenal insufficiency only. The color of excess pro powder. If the color secondary so pro monocardic dipeptides. Then there is fever. If fever there, then if patient has too much fever, persistent fever, then most for deficiency. Low blood pressure in women, and absence of adenaki and pivaki in children, adrenal aneurysm. So there are many patients who will have, hormones, testosterone, testosterone, they will not get here. So you may get a lot of, adenaki and pivaki when we absent in children. So this is also one of the signs of adrenal insufficiency. Okay, so these are some signs I've told you, and on the basis of sign symptom, you can say no deficiency there. So more important thing is that fever is persistent glucose deficiency. If the patient has got, glucose deficiency there, if a patient has got hyperpigmentation, which is commonly seen in primary insulin, this is excessive receptor peptide. And fever is higher, persistent, think of glucose deficiency. So the other one must kept in mind. So adrenal insufficiency is not a diagnosis. This should be very clear to everyone. The adrenal insufficiency is not a diagnosis. It's not you say adrenal insufficiency. It's not a diagnosis. So we have to find out why the adrenal insufficiency is. So let's start with this thing. Basic triangular is there. Adrenal insufficiency. What are the causes of adrenal insufficiency? So one very, very common is the adrenal gland has not been produced, either the dysgenesis or the hypoplasia. So this may be because of genetic factor. SF1, DAXA1 is ACH receptor problem. Okay. Then second thing would be there may be impaired steroidogenesis. So the pathway in the steroid pathway is affected from cholesterol to formation of cortisol, formation of maybe the testosterone, or formation of aldosterone. So there's some pathway effect in this pathway. So that is there. So maybe maybe there's cholesterol metabolism problem. There is Smith-Lepti opposite syndrome. Here you also have adrenal insufficiency. A beta lipoproteinemia, yeah, steroid biosynthesis, then star. This is one of the cholesterol lipid deficiency. Mitochondrial DNCH. So these are all impaired stenosis. Besides that, you have adrenal destruction. Your adrenal gland is normal, but it has been destroyed. Either it's an autoimmune problem, or it is adrenal leukodystrophy, or there's some infection, metastasis, amyloidosis. Now, in children, the commonest, I think, reason is Molly is commonly where you see it comes across as CH. And adults, it is commonly autoimmune or infection. In India, they're saying tuberculosis is one of the very important causes of adrenal insufficiency. So therefore, how do you approach? The next question, how do you approach a patient with primary adrenal insufficiency? So we can divide it three groups: less than 2 years, 2 to 20 years, and more than 20 years. So if the patient has got glucagon aminocorticoid deficiency, think of CH, canadiplasia, think of adrenal hypercortical, there's a hypoplasia of the cortex, or think of these other biosynthetic defects which I showed you the pathways. Or if there is child is more than 2 years, 2 to 20 years, there is, and if the child is more than 2 to 20 years and there's both glucocorticoid and aminocorticoid deficiency, think of adrenoleukodystrophy, think of autoimmune polycondritis syndrome 1 or autoimmune infection. If there is only less than 2 years, there is involvement of glucocorticoid, aminocorticoid normal, think of familial glucose deficiency or even star involvement. So the early pathway in cholesterol metal. And if the patient is 2 to 20 years and glucagon is only factor, mineral factor, think adrenoleukodystrophy, then you think of, again, familial glucose deficiency or triple A. Triple K means, academia, academia, eclasia, and Addison disease. So these things are there. So this is how you should, and people who are above 2 years will come with primary deficiency, most commonly it will be autoimmune or infection. Infection, where they say in India is most by tuberculosis. It could be infiltration, some novel infiltration. We'll talk about this in the next slides. Then it could be a autoimmune polycystic syndrome 2 or autoimmune polycystic syndrome 1. In polycystic syndrome 2, you have Addison disease along with hypothyroidism, along with diabetes. Wherein in APS1, you have hypoparathyroidism along with your Addison disease, and you may also have mucocutaneous candidiasis. And then is adrenoleukodystrophy. So this is a basic classification how you. So depending on the age, you can find out, do the glucocorticoid, aminocorticoid, you can pick up, this is the case. You do the glucocorticoid, aminocorticoid above 20 years, you pick up the case. And this is, so 2 to 20 years is commonly, do the glucocorticoid, aminocorticoid, you come out. Let's go, okay. Now as we go on further, let's start with a case. A 1-year female comes to you with failure to thrive, dehydration, and shock. Okay, this is the presentation. The genitals are normal, so therefore there's less chance of being a CH. There's no precocity, there's no hair, nothing of that sort. There's no mucocutaneous candidiasis, so that means this is not likely to be a case of autoimmune APS1, which is very unusual in later ages. There is no neurological complaints. Family history, there is nothing absent that where this child had this problem of periods had any issues. And the karyotype is 46XS. So the girl it's a 46XS girl, 1-year female, who's come to you with failure to thrive, with dehydration and shock. The ultrasound shows normal Mullerian structure. Uterus, ovaries are present. So you have ruled out CH, you have ruled out those conditions. Now, what is further to be done? Now, when we ask for the blood chemistry, biochemistry, the prolactin, the PR is slightly on the higher side. The ACTH is quite raised. The cortisol are very low. The sodium is low. The potassium is on the higher side. 17-oxyprogesterone is normal, so that rules out your CH. Your TSH is normal, FT4 now. So thyroid function areas are normal. Basically, your PR is more this is renin. This is basically plasma renin activity. PR is plasma renin activity. So patients, they may have a high or low dehydration. So here, what are finding? High STH, low cortisol, low sodium, a little high potassium. So you're both. That means your mineral corticoid as well glucocorticoid are affected. Right? A child is 1 year old. Now let's go to that table and see. So at the age of onset 1 year, you have both the glucocorticoid and mineralocorticoids affected. Now let's go to there. So we had seen in that when glucocorticoid and mineralocorticoid affected, it can be CH, it could be adrenal hypoplasia of the cortex, it could be other biosynthesis. So we have ruled out CH, 70-oxy normal, there is no involvement excess chromosome, there is no, genitalia normal, Mullerian structure normal. So that's up. So we are left with other biosynthetic defects or with adrenal hypoplasia of the congenita. That means there is something from the birth. So therefore, this fits in very well into a case of adrenal hypoplasia congenita. So therefore, going back to that same classification, adrenal destruction, impaired stenosis, adrenal hypoplasia. So this is here, it comes out. So here, this is what is happening in this child. So this is most probably, let's go to the how do the adrenal gland form? So adrenal gland, there is celiac epithelium with certain, transcription factor WL1, it combine the primordial germ cell, this primordial germ cells and this celiac epithelium will become a bipotential gland, and from other transcription factors SRY, in presence of SRY and SO9, it will become testis primordial, and in presence SF1 and DAX1, this gonad will become ovarian primordial. So you have got testes and you got ovaries. Now the same urogenite, once these it goes in the present S7 and DEXA1, so these epithelium will become neural, along with neural crest, will be with angiogenesis will form zonation and form a fetal adrenal gland. So SM and DEXA1 is for basically the transition factors is that forming the adrenal gland. So anywhere affected here, SM1, DEXA1, your adrenal gland will not form. So there will be hyperplasia. So this is what exactly happening in this child. So you have an hyperplasia with congenital because of one of these genes being affected, which I showed you in the slide when I made the classification, how you classify. So therefore, in this child, a 1-year-old with low mineralocorticoid, with low cortisol, so this is most by adrenal hypoglycemia, maybe involved S1 or DEX1, which you had to do studies. Coming on to another case, it's a 4 years male. Now because it's a boy, mind it. Hyperpigmentation seen from infancy. So from the age of 1 year, he was having hyperpigmentation. Failure to thrive, hypoglycemia convulsions. So he had hypoglycemia convulsions. So but alacremia was absent, dysphagia was absent, precocity was absent, BP was normal, 90/50. So basically, what we found in this patient was that the ACTH was very, very high. The cortisols were low. The sodium was also normal. The potassium was normal. 17-hydroxide was normal. And plasma activity was normal. So that means there is no mineralocorticoid involvement. So only glucocorticoid involvement is there. And there is no academia, no dysphagia. So that means that AAA syndrome is out. Precocity is not there, so CAH is also out. So you have only basically glucocorticoid involvement. So therefore, something is there in this child. And then let's go further. So if you see this is the growth chart of the child, where they're showing the mid-parental height is here, the child is here. So child is little, on the higher side of the height also. So therefore, what is important to understand is this, the age of onset when this child had it, now is 4 years old, right? Okay. But this onset was at the age of 1 year. So that's something. So the last 3 years, now this child has had this problem and he's having pigmentation, he's having failure to thrive, he's having hypoglycemic convulsions because of low sugars, and it does not have any features suggestive of, any pH or anything of that sort. And there is no acclimate dysphagia. So therefore you have glucocorticoid involvement without mineralocorticoid involvement. So let's go to that same classification, see what's happening. So this child is now 4 years, but affected in long back. So less than 2 year infancy. So this is glucocorticoid and mineralocorticoid normal. So it is either familial glucocorticoid deficiency or star. So star involvement is not there because we do not find any feature related to adrenal involvement, excess adrenal, or any other thing. So this is a typical case of familial glucocorticoid deficiency, where you have the glucocorticoid involvement and you have all these failure to thrive and all these things. And hyperpigmentation, as I told you, is a part of acute adrenal insufficiency. So let's go to this further, little more. So here you have got again familial glucocorticoid deficiency with existing involvement, and there also here you can see that there is beside this you have this familial glucocorticoid deficiency. Little more about familial glucocorticoid deficiency. So there is resistance of ACTH. ACTH is not able to act on the receptors and result in production of glucocorticoids. So therefore, there are different types of familial glucocorticoid deficiency. One is mutation in the MC2R receptor, melanocorticoid 2 receptor, so ACTH, or which is also called ACTH. So there is a receptor, ACTH receptor, there is mutation that, and because of that, the ACTH resistance. So there is a familial glucocorticoid type 2 mutation in the MRP gene is there. So here also there is impaired melanocorticoid 2 receptor transform the endoplasmic reticulum surface. So basically, there's a genetic we're not going to discuss, but just to know a little. So there's familial glucocorticoid type D, type 1, deficiency type 1, familial glucocorticoid deficiency type 2, and familial glucocorticoid 3. So it's unknown much about it. So this child was case of familial glucocorticoid deficiency, and the glucocorticoid was not able to act. So coming to another case, a 4 year male with hyperparathyroidism, with failure to thrive, with hypertension, same like that other child, but something different. So there was lacrimia positive and dysphagia in this child. Okay, so this child had acrylicemia and dysphagia. So coming on further, family history was absent. So there was no family history. If a family history was there, and like more likely with glucose, with a familial glucose deficiency. So that is important. So again, in this situation, the ACTH was very high, the sodium was normal, the potassium was normal, plasma activity was normal. So ACTH stimulated cortisol was very, very low. We'll talk about ACTH stimulation test in the next slides, but this is just to tell you. So what was thought of that maybe this child has got aclemia, eclasia with dysphagia and all that, so it's a triple A syndrome. So therefore, occipital manometry was done, which showed ecclesia cardia was it. So this was then typical case. So age of onset 4 years, glucose deficiency, mineralocortical is normal. Okay, so therefore you go on back to that classification. You you have 4 years like in this group. So glucocorticoid is deficient, mineralocortical normal. It could be adrenal leukodystrophy. It could be a familial. Again the same glucose deficiency, which we have already ruled out because family is not there, and triple A. So in this child was the case of triple A. So little bit more about this. So genetic analysis was done in this child. It was found that there was this homozygous spike mutation was there in this boy. So now we have talked about triple A and we have talked about this thing. So this again is on the side of adrenal dysgenesis, adrenal aplasia with triple A. So Addison disease, eclemia, and eclasia. So little bit about the triple A syndrome. It encodes alacremia, eclasia, adrenal insufficiency, along with neurological disorder. So there's a protein which gets enhanced and patients have neurological disorder also with that. The earliest and the most consistent feature is alacremia. So lack of tears, if you find a child, lack of tears, with little dysphagia, think he might go into Addison's tomorrow, adrenal insufficiency. So now we talked about this. So therefore the next is impaired steroidogenesis. So we'll talk about another case like that, where we talk about, where we have impaired steroidogenesis at which level. Then come the adrenal destruction, destroyed destruction because autoimmune adenitis, adrenal leukodystrophy, an infection, metastasis, amyloidosis. So all these conditions can cause destruction of adrenal and result in acute primary adrenal insufficiency. Then you are talking impaired steroidogenesis. So this biosynthetic pathway in steroid production of cortisol or aldosterone, some may defected. So they may be because of STAR, because of CH, some cholesterol metabolic affected. So you have a Smith-Lippi-Opert syndrome, and here also your cholesterol metabolic affected, and as a result of which the adrenal glands are affected, and ultimately the production of cortisol is not that good. So you may have adrenal involvement in this Smith-Levy-Opert syndrome. The A-beta lipopreneur. So coming on a little more, a third case, which we'll talk relate to the third thing which I told you, that impaired steroidogenesis. So this is a child who is born full-term normal vaginal delivery, non-consensual marriage, cried immediately after birth at 3.0, no abortions in December 2000. After 1 month, there was failure to thrive, body weight started decreasing, hyperpigmentation started increasing. So at 1 month, he was 2.8, so he lost 400 grams. Okay, so then the biochemical finding of hyperkalemia, hyperuremia, increased 70-deoxyprogesterone more than 1,000 nanograms. So this is a typical case of congenital dysplasia because steroid biosynthetic defect. So the diagnosis was made with 25-deoxy deficiency, classical salt wasting CH. So it was mutation proof. So he started on hydrocortisone and started doing well, and followed up with different levels how to follow. We'll talk more about that later. So but just to tell you that there are a lot of CHs can present as salt losing crisis, and they can just be like an adrenal picture. So therefore you have the various ones can present 25-hydroxylase, 3-beta hydroxylase star, POR. POR is basically there's a oxidative enzyme, and that oxidase 450, and there's some involvement in that, and it causes your patient to have low mineralocorticoid. So congenital hypoplasia, SF1 DAX mutation, I already told you was similar. I already told you Then AAA, we already have adrenal leukodystrophy. So basically, so therefore, from cholesterol till aldosterone, you can see so many pathways are there: prednisolone, progesterone, corticosterone, adrenal. So any of these enzymes, 21 hydroxy, 17 hydroxy, your star, and the 3 beta hydroxy, 21 beta, any one of them can be affected, and as a result of which you can have your resistant crisis. So that's why, just to tell you that only not just plain 20 peroxide, there are other causes of having CH with salt losing, because so many pathways there for forming cortisol and aldosterone. So many, anywhere it is affected, it will cause it. And many of these pathways will result in androgen production. So in that case, you can have different features and different types of CH. So this is just to make you, this is the steroid pathway. So now next come, we just talked about the causes and we talked about 3-4 cases. Now how do you diagnose a patient adrenal insufficiency? That's important to understand. So there are three optimal diagnostic tests mainly. One is the standard dose, which is also called A stimulation test or corticotrophin stimulation test. Then there's a low dose corticotrophin test, and then the others. When you can do, when you have, you are not getting a corticotrophin available and you're difficult in getting it, so you can do monitoring of cortisol and ACTH along with that. So therefore, ACTH stimulation test, it is done in neonates, 2 years, 2 adults, everyone. So the ACTH, and if you want to do an prove a neonate, something which we did, so you give 15 microgram per kg per neonates. Up to 2 years, 125 micron, above 2 years, 250 micron. So doing a stimulation with 250 micron and checking level of cortisol. If the serum cortisol after 60 minutes is more than 18 microgram, finish. It is not adrenal insufficiency. So this is a gold standard test. If yours more than 18 micrograms after 1 hour after ACDH, so this means that this patient is not a case of adrenal insufficiency. Okay, so it's very important to understand. Now, suppose you cannot do the ACD stimulation test at that time. So what are the other ways? So you just do morning cortisol in combination with ACDH. The morning cortisol will be less than 5 microgram per deciliter. That means you're going toward adrenal. That means you're most probably dealing with primary illness. Along with a raised ACTH, which is more than 2 times double of the upper limit of normal. If the upper limit of normal is 200 and more than 400. So like that, if the value then only can say this. Morning cortisol less than 5 milligram per hour. So these are some preliminary tests which suggest adrenal insufficiency until you have a confirmatory test with corticotrophin stimulation. Okay, so this is something must know. Now there is that low dose I was talking about. The low dose corticotrophin is done only when you cannot get corticotrophin, and mainly it is more helpful in secondary adrenal insufficiency. If you compare the low dose with the normal, corticotrophin stimulation, the sensitivity, it does not add further to sensitivity or specificity for primary adrenal insufficiency. It is higher sensitivity for diagnosis of secondary adrenal insufficiency. So therefore, low dose will be more helpful for secondary adrenal insufficiency as compared to primary. So this is something one. So basically, the diagnosis by the corticotrophin test, or we always say ASTS stimulation test. More than 80 microgram per deciliter after 1 hour, rule out adrenal insufficiency. Now, very important, all males, again I'm saying all males who are diagnosed with primary adrenal insufficiency, we do not have etiology, must do plasma very long fatty acids. So there'll be VLCA will always be in green in these children, will suggest of X-linked adrenal leukodystrophy. So if they are normal, you can rule out clear-cut X-linked, adrenal leukodystrophy is not there. So this is something, it's a big, it's like a table, but difficult to understand. I'll just tell you broadly the things. So what should you look for a patient adrenal insufficiency? If you have autoimmune etiology, it may be isolated autoimmune, nothing is there, or there may be other autoimmune disorders. So if you have APS type 1, as I already told you, chronic cutaneous candidiasis and hyperparathyroidism, APS type 2, autoimmune thyroiditis type 1 diabetes. If there's adrenal infiltration or injury, adrenal hemorrhage, adrenal metastasis, infection, adenitis, you may have, hemochromatosis there, you may have tuberculosis, you may have candidiasis, you may have histoplasmosis. So these are some things, you must remember that. Or bilateral adrenectomy has been done because of, Cushing syndrome in the past. So CH, I already discussed with you, very common cause of primary illness in children, and 80% may be diagnosed in also in older. So the commonest is 21, others 11 beta hydroxy, 3 beta oxidation, P4 side chain, P5 deficiency, P4 oxidation deficiency. So there are some manifestation along with this, like in P4 oxidation deficiency, there's skeletal malformation of normal genitalia. So that then there's star mutation, there's congenital lipid hyperplasia. There's an XY sex reversal, in these cases. So adrenal congenita, then ACH, then there are a lot of drugs which can present, we must think of when the patient comes with the, this. So like metotane, ketoconazole, metoprolol, amyloglutamide, they may excite cortisol metabolism and induce adrenal insufficiency. So that is there. Then they have other metabolic like mitochondrial disease. I already told you about adrenal. So these are other conditions. These are main conditions you can have. So when you have something elsewhere, then think of these things also. So what is the treatment? The next question, very important. How do you treat these patients? How will you treat this patient, who has got mineralocorticoid deficiency or has glucocorticoid deficiency? So the therapy is hydrocortisone. Glucocorticoid is the term of choice. The hydrocortisone is a glucocorticoid. So there is no confusion to make it dexamethasone or prednisone. Hydrocortisone is a drug of choice, glucose of choice, and acute adrenal insufficiency, primary adrenal insufficiency. Cortisol production in the normal subjects is 5 to 7 to 7.4 milligram per meter square. So that's why in patients, you do a replacement of the dose around 8 to 10, maximum 8 to 12 or 10 to 12 milligram per meter square per day. You need more doses in primary adrenal insufficiency as compared to secondary adrenal insufficiency. So now, if there is a crisis, how do you manage the crisis? This we talked to general patient who are having adrenal insufficiency. What do you do? So give a rapid bolus. Patient having hypertension and shock. So give him bolus for normal saline, 20 ml per kg, and you can repeat up to a total of 60 ml within 1 hour shock. Give hydrocortisone IV, then bolus 1500 milligram per meter square, and then follow by hydrocortisone 1500 milligram divided into every 6 hourly. Okay. And then along with that, for hypoglycemia, even patients who are going in for surgery or CH patient, other patients who are having, hydro deficiency or their adrenal deficiency, you have to give them IV hydrocortisone. So hypoglycemia, just give 2 to 4, better to give them 2 to 3 ml per kg of, or 5 ml of 10% dextrose. Children less than and higher adults, you can give them, 0.1 to 1 gram per kg of dextrose, 2 to 4 ml per kg of D25, and over a rate of 2 to 3 ml per minute. So cardiac monitoring is important. Whenever it's rapid taper switch to oral depending on care. So you must keep on monitoring the patient and and then taper off from the hydrocortisone IV to the oral hydrocortisone. If the patient started eating oral, the patient is being better, you can. When you should shift to oral dosing, once the patient is stable, add hydrocortisone in 3 to 4 doses. The total is starting 8 milligram per meter square, and with dose adjusted according to insulin. Do not give long-acting glucose, prednisone, dexamethasone. Avoid giving that to these patients once they're out of this. And if children with confirmed aldosterone deficient, add fluorocortisone. Okay, starting dose 100 milligram per day. And some of the smaller children, who have salt wasting crisis, who cannot fund, give sodium chloride supplements in the newborn and make up to 8 or 12 months. Now we have talked about the treatment. We talked about urinary crisis. We talked about the diagnosis. We talked about various conditions which is causing adrenal and primary adrenal. Now, how do you monitor these patients? That's the most important thing. How do you monitor this patient? How do you know that you're doing well with this patient? You're giving the medicine okay or not giving okay? What's going on? So monitoring is very, very important. It's a more a clinical judgment. Okay, remember this. Monitoring a glucose treatment is a clinical judgment. That is never on the basis of plasma state levels because you plasma estimate 200, 300, 4 after you start hydrocortisone maybe 100. So that does not tell you anything. And cortisol day curves are made, urine-free cortisol, salivary cortisol. These are not useful for monitoring because many of the institution, many of the doctors, they will do see plasma level and you do even they might do urine for its upcoming normal, so fine. So the important thing is to maintain a plasma renal activity upper normal range. That should be done. Okay, then you're coming, the further monitoring is, that means whether you get the patient, your patient is coming and tell you very still feeling fatigue, I have nausea, I have myalgia, lack of energy and weight loss, there is under replacement. If there is weight gain, central obesity, osteoporosis, impaired glucose tolerance, and hypertension, over replacement. So them have that. Fatigue, nausea, lack of energy, and weight loss, you're not be giving your medicine problem. You're under replacing it. So you need to maybe go up from 8 milligram meter to 10 milligram per meter square. You may have need to go to 11 milligram per square. And if there is weight gain, central obesity, osteoporosis, impaired glucose tolerance, hypertension, you're over replacement. So you have to be very careful in balancing these things too. So, so with this quick closing off, another algorithm for the diagnosed course to patients with primary insufficiency. So primary insufficiency, infants, selected children, adults do a 17-hydroxyprogesterone. If the 17-hydroxyprogesterone is positive, CH. If the 17-hydroxyprogesterone is negative, think of some genetic syndrome like rare CH or adrenal hypercortical hypoplasia. If this is not there, then idiopathic cause, we do not know. It's a idiopathic primary insufficiency. Now, if you all above 6 months, you can do a 25-hydroxy antibodies. So if the antibody is positive, most probably is autoimmune. You can also consider APS1 and APS2. Now, if the antibody is negative, then get a CT of the adrenal glands. So you have to find out whether infiltrative disease, whether adrenal hemorrhage, whether the infection, or whether there's malignant tumor, or maybe if this is there, CT adrenal is positive, then think of this. If the CT adrenal is negative and 20-hydroxy is also negative, then you must go on to think of a genetic syndrome. Like as I told you, adrenal hypoplasia congenita or CH. So if you don't find idiopathic primary insufficiency. Now, if the patient is negative, and it's a boy, very important. 20-hydroxy negative, all above 6 months, it's a boy. So get a VLCF done. So very low chain fatty acid done. If that is positive, adrenal leukodystrophy. So you have, in a short nutshell, this is how you will go further in diagnosing it. Okay. So the take-home message, very, very high index of clinical suspicion required. Which failure to thrive, slow shock, tiredness, myalgia, not gaining weight, all this has to be kept in mind. The early diagnosis and treatment is the key to success. You may not let the patient die off because of shock, because not thinking in that direction. Maybe patient coming, knows you just think it's gastritis, nothing else. Some pain of the abdomen, so gastritis. No, think of something else. So etiological diagnosis is very sometimes important. Then if you pick up some cases where you have found up, cause, then genetic counseling is required. Monitoring is very, very important, because monitoring, and there is no one single test or one single way you can say. So you have to see the symptoms, whether it's on this side, that side, whether under treating or not. So thank you very much for joining in, and I'm ready to go back to any question answer session.
Thank you so much, sir. It was a very comprehensive talk. And we have received few questions from our participating doctors. So, sir, with all your permission, can I put them across?
Yeah, sure.
Okay, sir. So for today's session, our very first question is from Dr. Agarwal. Sir is asking, what are the potential complications or risk associated with primary adrenaline insufficiency and how they can be mitigated?
So as I told you, the very, very important thing is hypertension, shock, and death. So they may come straight to you in coma, they may come straight to you in very low blood pressure, they may come to you in shock. So the way the mitigate is, think high index of suspicion is very, very important. So if any patient you come is little pigmented and you find, because primary adrenal insufficiency, pigmentation will be there. If it is present for a few days and then he's gone into acute adrenal crisis or adrenal crisis, then you will find. So if you have a patient who is a little blackhead running, he's having shock, he's not understand what it is, get his mineral corticoids, get his glucocorticoids, get his potassium, sodium, and then you see what's happening. And the best thing to mitigate is go to think of it and then treat it. It's very easy. Just treat it, give hydrocortisone immediately in fluids. The patient responds very fast. So there's some condition which is treatable and which can be made patient respond. But thinking is thinking in the mind about it. That's all. That's very, very important. So if you have a condition where the patient is persistent fever, patient is in shock, patient is hypertensive, patient is then you think of this and you immediately either give bolus fluids and give hydrocortisone, immediately they'll come back.
Thank you so much, sir. So coming to our next question from Dr. Majumdar, sir. Sir is asking, according to you, what are the appropriate follow-up intervals and monitoring parameters for patients with adrenaline insufficiency?
So as far as the follow-up is concerned, I just told you that, you have to, once you are diagnosed, once you're treated, and when you stabilize a patient, you can monitor them every 3 to 6 months. And what is to be monitored? Monitoring is basically clinical signs. You cannot make on the basis of cortisol level, you cannot make on the basis of uniform cortisol, you cannot make on salivary cortisol, you cannot make on the ASTA level. So what is more important is the science. So if the patient is still not gaining weight, patient is tired, patient myalgia, patient is looking always at, behaving and not gaining weight, not interested in so on. So that means you earn the treatment. So increase the dose of hydrocortisone. And if the patient is, being treated and you're giving dose and patient getting hypertensive, patient obese, patient is getting, the different in a behavior, and maybe even some patient maybe, having a weight gain too much. So then you think you're over treating the patient. So decrease the dose. If it's 12, make it to 11, make it to 10. So this is basically how you monitor these patients, but every 3-6 monthly. Some people are doing electrolytes in case of mineral corticosteroids. If your sodium potassium normal, that means your mineral corticosteroids is fine. And you may do, because see, even any of these patients, acute primary adrenal insufficiency, with the depending on the cause, you can do an AST level, but this is not at all reliable. Because AST is not, we do not know, it's 200, 300, 400, 600. What is the cutoff? We can say that, oh, he's doing fine. So there is nothing like that. So that's why monitoring 6 months, more of monitoring with your symptoms of your over or under treatment, and then according to treat the patient. The best thing is to calculate the weight and height of the patient, and then find out this, surface area. Once you find the surface area, and then you multiply it by 8 or 10 and start the dose. 90% of these patients are, they become fine. They are not overtreated, they're not undertreated. And once they become fine, the symptoms are okay, that means you're doing all the right. So you can just follow them every 3-6 monthly.
Thank you so much, sir. So moving on to our next question from Dr. Tripathi. Sir is saying it was a very nice and compact presentation, and sir is requesting you to once again describe the slide of AAA syndrome.
Yeah. So AAA syndrome basically is a syndrome where, you have involvement of three main things. Aclaimia is very common. So they tears absent. There will be a child, many times parents will come with children where they say that there's no tears coming, there's no tears coming, there's no tears coming. So people say, oh, jayega, bhai, there's no problem. It's a developmental, you tell the patient, doctor tells him, okay, it'll come, don't worry, don't worry. And the same patient comes to you after some time, that he has difficulty in swallowing, there's difficulty in swallowing. You ignore it, it's the take a pani pulao, give him, instead of solid, give him liquid diet. He comes in crisis. So you have distance. So basically you have three main conditions: leukemia with, achalasia with adolescence. So that's why it's called a AAA syndrome. Genetically, you have to find out the genes for it because it can run in the families. That's why family history is positive. You can find in the families therefore. And third thing is that it's, as I told you, it normally occurs, children like in above 2 years age. The presentation on it starts at early. The first thing to always present aclaimia. So that means there's no tears formation. And as I told you that in some of these cases, there may be involvement of neurological also may be there. So that is also there in some cases, they are neurological one, but that occurs very late. And most of these, the patients will, the family, the history may be available. So maybe in some genetic or some mutation or some this thing, the gene which is came is not clear. So there may be the parent who has it, but she has only achalasia. She does not have other features. But in this child, you got aclaimia, you got achalasia. So that's why it's called AAA syndrome.
Thank you so much, sir. Sir, you can stop your screen share so that people can see your face full screen. Yes, sir, it's perfect now. Okay, sir. So coming to our next question from Dr. Jain. How can you support patients with PAI in managing their condition, including lifestyle modifications and self-monitoring of symptoms and medications adherence?
So it's a very long answer also. It's a very long question. So basically what you have to do is that you have to tell your, your patients that you have to take, because the magic drug is hydrocortisone. Remember that. And that drug has to be kept with him wherever the patient is going, wherever the patient is moving on, he has to keep that. Now his adrenal glands are not functioning, there's adrenal insufficiency, so he has to regularly take hydrocortisone. Now, if there is some other problem, like he has a high grade fever, acute gastroenteritis, he has some other, so in some cases you have to double the dose also during that crisis time. Because if you don't do it, the whatever dose you are taking is not going to manage the stress part. So that's why you must add sometimes stress dose, which is slightly a little more than the normal doses. So next 2 3 days you might give a stress dose for the high grade fever or for this thing. And so once they're stabilized, you just tell the patient, be sure lifestyle is that eat normal, good food, everything, and take your medicine regularly. And once you're sure the patient is knows the nice symptom, like as I told you, under treatment is myalgias, weight loss, not gaining weight, not interested in environment, getting tired always, and persistent pigmentation increasing. So that's why these are the patients. And then you have to change the dose. And the opposite is there for over treatment. So basically, you have to monitor that on the basis of symptoms of these patients on under treatment, over treatment. And very, very important is the compliance. You must explain to them that you have to take your medicine hydrocortisone daily, regularly. And fluorocortisone is very easy, just once a day. Hydrocortisone, you might like to take it twice a day, thrice a day, depending upon it, because the half life of hydrocortisone is not much. So if you give it 8 only, you get a better response as compared to 12 only. But you can try in that. But and then for very important is that in these patients to take mineral corticoid if they are getting low sodium. So it's easier to follow up with sodium and potassium for mineral corticoid, but for hydrocortisone, it is based on symptom and this thing. So calculating a dose on basis of surface area. You cannot on the basis of ACTH, you cannot on the basis of other values make a comment that okay, hydrocortisone is fine.
Thank you so much, sir. So coming on to our last question from Dr. Mukherjee. In your experience, how do you educate patients and their family members about PAI, including signs and symptoms of adrenaline crisis and the importance of medication and regular follow-up care?
So what I do is I tell all my patients, the first thing once I diagnose, depending on the case, whether it is CAH, whether it is, adrenal hyperplasia, whether it is, other causes, whether there is some autoimmune cause, whether there is adrenal leukodystrophy, and, all will have different prognosis. So that's why it makes a difference. So that's why I tell all the patients is that you follow them up, with your medication properly. And if you have any fever, high grade fever, as I told before, that if you have any of this, so just increase double your dose during that time. And after that, you come back to original dose, original dose, and then we will have this thing, original dose, and then we will. So what we are trying to explain to patients is and compliance is very simple. When anybody of these patients do not comply, they will get crisis. They will have problems. So they will have problem blood pressure. They will have problem hypertension. They may have tiredness. Or lethargic, anorexia, vomiting. All these things will start occurring. So they understand that and they start becoming compliant. So most of the patients of this primary adrenal insufficiency are very compliant in their medicine because they know they cannot do day-to-day work if they miss their medicine 3 4 days. So that's important to understand. So the compliance issue is normally not there unless if a child is very small, around 2 years, or they won't understand. So it's the parent's responsibility to see that he takes regularly medicine. But the others are very adolescent and adults are very compliant. So that's the thing. And then just explain to them that if you get, you feel tired, you feel weak, you feel lethargic, you feel that, you cannot do your day-to-day work, you're having headaches, you're having fear of nausea, you feel that, you're not, appetite is not good, or vomiting, come back, come to me, back to me. So I explain to all these things and then, that's it. So what we do is immediately we get, your electrolytes, we get the cortisol level, we get to pick it up and see what's happening. Although they're not really right because they're always, the cortisol levels are not the same throughout the day. So they may be at a peak in the morning time, then the afternoon decreasing and the night decreasing. So different is. But basically do electrolytes. That is all this thing. Once we know it's adrenal patient, just increase the dose from 8 to 10, 10 to 11, and then see what's happening and then follow up this patient. And whether with this improvement of the symptoms, you know that you're on the right direction. So that's the most important thing. So if the patient comes and says, I'm feeling better now, I'm okay, now I'm not, whatever I'm feeling of tired of all this is not become less. So that's the important thing.
Thank you so much, sir, for answering all the queries from the doctors. And thank you so much for sharing such valuable insights. And I would also like to thank our participating doctors for their continuous participation at our platform. So, sir, with all your permission, I would like to sign off for today.
Yeah, yeah.
Have a nice day, sir.
Thank you very much. Thank you.